we'll show what we have, and then we'll call it a day whenever. And like I mentioned, Howard won't be here. So I'll start off real quickly if that's okay. And that way, if I get any consults, I can deal with those while you guys show your cases. Let's see. All right, so I have I have a couple cool cases. This is a fun one. This was a one I got to I saw this portable radiograph, and I can't remember why the patient came in like chest pain or something, and I had no comparisons at the time, but this caught my eye, the azygos here, and I was like, I wonder if he's got something congenital going on, because that's a really big azygos. Otherwise, looks normal. I was trying to look at his airways though, and I wondered if this bronchus is under the pulmonary artery. But luckily he happened to have. I checked back later, and he happened to have a spine MRI the same day later that evening, and all I saved was the localizers, because that tells me everything I needed to know. And you can see indeed he's got bilateral hyperarterial bronchi. He's got a monster IVC. I'm sorry, not IVC. Azygos. Where did it go? There's the arch. There's the azygos vein. And then if you look in the left upper abdomen there's polysplenia. So this is a guy with left isomerism, incidental detection, just kind of fun case. And going back, I'll mag in on the hilum again. I think it looks like a sort of a two left lungs here, and I suspect the artery's right here, and so it's just hyperarterial. So that was the first case. This is kind of cool, and I'm sure I wouldn't be surprised if you guys are doing these more often. So we've started doing CT esophagograms. We're kind of late to the game, which our residents love because they don't have to do fluoro in the middle of the night, and the staff like because they don't have to do fluoro during the day for leak checks and stuff. But so this patient carries a diagnosis of eosinophilic esophagitis and came in with chest pain, and they were worried about a rupture, and so we did a CT esophagram late in the evening. And this one turned out quite well. And you can see there's a nice column of contrast. And then you can see a nice little mural defect here, not all the way through, but a mucosal defect at least, or quite at least 2 levels here. And then you can see the diffuse thickening of the esophageal wall, and then a tight junction down here. So, and I've made MIPS of these before to kind of reproduce the esophagram effect, but just a nice case of an incomplete thickness, long longitudinal tear of the esophagus in the setting of eosinophilic esophagitis. So makes it one-stop shop, because a lot of times if the fluoro is equivocal or it's positive, they ended up getting the CT anyway. So we were able to do these all at once. So we do it for a suspected rupture. We just do we have them drink a little bit and scan, then we do a second drink just to make sure. And then if it's a leak check, we do a non-contrast first, followed by a bolus, and it seems to work pretty well. We modeled it after that paper. I think that was an AJR several years ago, but there's good literature behind it. So, and it's just a non-contrast chest with a modifier for the contrast in the protocol. All right, and then David will like this last case, because we've talked about this before, and I got fooled on this one. I was suspicious I was going to get fooled, but I couldn't let it go. So this patient has pneumomediastinum, subcutaneous gas, and I thought this was going to, I wondered if this was going to be a pseudopneumothorax or not. But to me, this was pretty convincing that it was going to be real. There's some streakiness out there, but that looks like a pretty good visceral pleural line to me. So I called a small pneumothorax. But they got a CT later on for a different reason, which I think they were looking for the source. But you can see, indeed, there is no pneumothorax, at least not convincing. I think this is all pseudopneumothorax here. And then you can see really nice interstitial gas. This is one of the better ones I've seen in a while. So a nice example of the Macklin effect with interstitial gases. It's on both sides. You can see ring around the arteries and all that. So unclear exactly why this happened. I don't think the patient was asthmatic or what they were doing, but I don't think they got the whole story. And she was intubated. I believe she was altered, so she may have been on drugs or something. And Oh yeah, I think we did this as, I don't know if we did this as an esophagram protocol or not. No, this is just contrast from the belly, but you can see we got a free esophagram out of this one as well. So Macklin effect, pseudopneumothorax, mimicking a real pneumothorax, um, and pneumomediastinum. All right.
Just a point question for everybody involved. How many times have you, they always seem to get CTs for these patients. How many times have you actually seen an identifiable cause for the pneumomediastinum on the subsequent CT?
Never, except the
non-traumatic patient.
other than interstitial gas, never.
Yeah, I mean, right. No, you see the interstitial, right? You see the PIE, right. But like where you're like, yeah, I just always try to explain that the chances of us finding something to do something with is almost none.
Yeah, I actually,
hey, Seth, circa, well, I was gonna say circa like 2011, 2012, one of my co-residents at Mallinckrodt wrote it with Sanjeev. They looked at like 100 cases of pneumomediastinum, and you're right, like there were a couple findings you would see with esophageal perforation, but otherwise they're always just spontaneous pneumomediastinum like this.
Yeah. No, it's like, yeah.
If you need something to push the ED away from actually doing it, there is some literature.
Okay, but, yeah, I didn't know that, but okay, no, that's good that it's out there, because yeah, I always try to say, well, why are you getting the CT? You're not going to.
Right, exactly. There's no reason.
Yeah. Agreed. And then they order one for PE, so
yeah, right. Yeah, exactly.
All right, who'd like to go next?
I can show my cases.
All right, there you
go. All right, so I apologize. We just went to Visage this Monday, so we're a little discombobulated, but hopefully one day I can show these through Visage and not Terra. But so this is a young patient. I think she's 42, came in to the ED from the outside hospital. And I think everyone can see that, basically the entire left main territory is not moving. Maybe, yeah, it's really not moving. The whole anterior septal, anterior lateral going into the inferior lateral maybe has a little bit of movement. So what's impressive about this is, this is something we've all seen. Is just the severity of it is just striking, at least for me. Let's see, yeah. So this is her delayed enhancement sequence, and we can see that it's always bad when you have infarct and you have no contrast within the areas of infarct. So this is infarct that's enhancing around the kind of looks like, one of my residents got fooled, thought this was some sort of non-ischemic process because of the enhancement kind of in the mid cavity going to the epicardial layer, but all this hypoattenuation in the, or not hypoattenuation, basically just complete black in the subendocardial layer. So this is a case of really horrendous microvascular obstruction. So basically the subendocardial layer, which is the most severely involved, is so edematous and filled with hemorrhage that the basically gadolinium can't even diffuse into that area to show any enhancement. So probably, I don't know, I see MVO probably once or twice a year. We don't do a lot of acute infarct imaging, but this is probably the worst case I've seen. I'm sure there's worse cases out there. It's just something we don't image a lot of. And just to show it in some different planes, this just black here is just all, and that portends a horrendous prognosis. And so the question is, well, why did this 42-year-old have a left main territory infarct? And we're still not 100% sure. They did a cath on her and thought it was vasospasm because they injected into the left main and thought that they saw transient narrowing of the distal left main. But I think on, which it may be, but I've never seen mean, maybe it's out there. I've never seen a case of proven vasospasm lead to, I mean, this severity of infarct. But if you go into this area here around the distal left main going into the LAD and left circumflex, you do see this abnormal soft tissue kind of at the ostium of the distal left main going into all this around here. This is not obvious. This is not normal. The circumferential soft tissue here. It's also around the circumflex. So we, even though they're calling her vasospasm, we really think this is a, and you can even see it going into the ramus here. We really think this is going to be a 2 or 3 SCAD, depending on if it's a focal SCAD or if there's other areas of involvement, which make much more sense than a vasospasm. You're not going to see the residual abnormality with the vasospasm there in the coronaries. And even here, you can, I mean, just see how bad of an infarct this is, right? I mean, it literally is the whole left main territory. So it's amazing she's still alive, but presumably she's going to need a heart transplant at some point. And this is, oh, this is a good case. Let's see here. So this is a patient who presented with, what was this? I didn't download the most, oh, shoot. Okay, there's one missing that's before this that shows much worse, yeah. That's really, everyone, well, I'll show it anyways, let's see. There's one before this that shows much worse septal thickening and ground glass throughout the lower lobes. It really looks like some sort of acute lung injury, but there were areas of mosaicism. And when you went to the upper lobes, there were some central lobular nodules, although, you know, not as conspicuous as this, more fluffy, but they were definitely there. So it looked more like an acute lung injury. And at this point, she's already had her biopsy. So this was before that. So she was a woman from Iraq, and you know, there are questions about, does she have some inhalational exposure there, or something going on there? Anyways, long story short, she turns out when that first CT came up with the kind of, and this is now a couple years later, and it looks very, very similar. Some of the central lobular nodularity in the upper lobes maybe a little bit better, but it's still there, and still has the ground glass and mosaicism, which really hasn't changed in many years. And she's been on steroids. When she got here in the United States, back in, I think the first study we had was 2017 or 2018, her husband got her some pigeons that lived in the house, and she developed really severe symptoms after her first time doing some extensive cleaning on the pigeon cage. So the first one I don't have was a really beautiful example of truly an acute hypersensitivity pneumonitis. You know, not the what I call inflammatory, but really, you know, what other people call the kind of, you know, I don't know what people call, because now people are using acute to describe what I, you know, to kind of comprise both what I always termed, I don't want to say, kind of in the inflammatory phase where you have continued inflammation. But there truly is an acute form, which is an acute lung injury that is basically has characteristics of HP and acute lung injury. And then there's more this form, which is what I call inflammatory, some people call subacute. And then obviously we have the fibrotic form, which this patient doesn't have. I have a bunch of path on her, but the path is really gorgeous. Very beautifully shows how airway centered these lesions are. So you can see the injury where you look is centered on the respiratory bronchioles, right? So beautifully centered on the respiratory bronchioles, where the intervening interstitium does have some inflammation, but not as bad. And then if you look around the airways, there will be giant cells all over the place. I have some other, here's a giant cell. I have some other images, path images, but fortunately don't have the best part, which is the first study. But we don't see the really acute form very commonly. I don't know. I mean, I know there's people are using this new classification. I don't know who came up with it. I use my own classification that doesn't help anybody, but you know, I break it down into the acute, which is an acute lung injury, versus the inflammatory phase, which is due to lymphocytic infiltration and inflammation, and then the fibrotic phase. But I know other people. What do other people use now? They call it acute and then chronic, or acute and fibrotic.
It's non-fibrotic or fibrotic is what I think the ATS guidelines are, and it does. Yeah, I agree though. Like the true acute HP seems different than that too. You know, because I think they're more talking about what used to be subacute with just central lobular ground glass nodules being the non-fibrotic form.
Exactly. But it kind of leaves out the acute form, which is super rare anyway, so it's probably not a big deal. It's left out. It's just you know, it's just super rare. But and then this is, you know, this is a case where I don't remember what this was for, but this patient came in. He had this lesion here growing for a study or two before this. This was missed, which I mean, I can understand, you know, we're reading fast, and there's the lesion here in the RV with some adjacent pericardial fluid. It's more conspicuous. Then the patient had a belly CT, an angio runoff. So he had a history of a squamous cell. And then he had a runoff study of the lower extremity, and you know, this was missed as well, which is, I think, a little more conspicuous here. Clearly a mass in the RV with some pericardial involvement. I don't think you can see it on the PE study subsequently because there's no, but yeah, I mean, this isn't normal either. Unfortunately, I think it was missed again. Or maybe it was caught here. I don't know. At this point, it doesn't really matter. But this is the MR, and it's really kind of impressive if you look at the, let's see if I can get this to open up in some form of normal fashion. Let's see if this will work. So this patient just has now raging pericardial constriction from this very necrotic, ugly tumor kind of invading out from the wall, from the RV itself into the pericardium. Let me show the images. So, you know, here you can see the tumor, which is now more in the wall of the RV, but now really kind of throughout the pericardium. You can see all this tumor in the pericardium all around the heart. Here's that septum kind of having the nice wiggle. And, you know, it was red, and the read was more just saying there was a tumor, didn't really give a differential. Here's see if I can get this to open. And this tumor had a lot of necrosis in it. Can't find the T2. I'm not going to waste too much time, but on the T2 weighted imaging, there was a lot of necrosis in this tumor, and they were going to biopsy it. This is a case just from the other day. These are single shots, not the best quality images. I don't know where my high res delays are, but anyways, there was debate about kind of what this is, but I didn't think personally. I didn't think there was a ton of debate. I've seen this now a couple times. So the guy has a squame. Look, I mean, just crazy pericardial constriction. I mean, his heart is so encased. So this guy has a squame of the head and neck, and I've seen now a couple times metastatic squames go exactly to this area. You know, lymphoma is not going to be necrotic like this. The thing didn't perfuse at all. I mean, it perfused a little bit on the perfusion images, but it was so necrotic that you know, most of it didn't perfuse. You see all these areas of necrosis. It's not you know, angiosarc's not going to do this. They don't really necrose like this too much. Lymphoma doesn't do this either. So, you know, I'm telling it's going to be a metastatic squame, and they're kind of saying, well, that doesn't happen. You don't get these. And I was like, well, we have a couple cases from here, but I don't know. I mean, the other thing you could think of theoretically was a pericardial meso, which is a good look for this, but the only thing that doesn't go with that is it's super rare and he has a history of a squame. And the other thing is that we have older studies which show that there was a, clear, in my mind, a clear cardiac mass in the RV at some point. And I don't know why Mets like to go here as well as primary tumors. I'm not really sure about what this region is that kind of leads to tumors loving to go there. I don't know if it's for Mets, if it's hematogenious and they just deposit there, or even why lymphoma and angiosarcomas go there. I don't know if anyone has any other thoughts of what this tumor would be, but anyways.
I wonder if something with just the hemodynamics is favorable there relative to, say, the high pressure left ventricle and high flow areas. I wonder if that's why, or maybe it's with lymphatics that we don't know about.
Yeah. I used to ask the guy I used to work with who wrote all the WHM tumor books. He never understood it either, why they went there. But yeah, I mean, they're gonna just treat them and not I wanted them to get a biopsy so we can, definitively see what it was, if it was truly gonna be a Met or something else. But they're gonna just treat him, and he's obviously not doing so well. So.
And you think it's myocardial or pericardial? So, like, where did it start?
I think it started personally, I thought it started in the myocardium, given this.
Okay.
So it was more severe early on, kind of in that wall here, and then I think it grew out. But
So,
yeah.
What was the primary? You said it was a squamous cell of what?
Head and neck.
Was it head and neck or?
Yeah, it was a squamous cell, like a laryngeal squamous cell or something.
Yeah. Yeah, no, I've seen one case of like a massive metastasis from a head and neck squame. Not saying that's the only one that would do it, but I agree, that's the most likely thing here.
It's just most likely, given the history. I mean, it could be something weird. Yeah, I mean, right, could he also have a pericardial meso? I mean, I guess, but those usually don't have a ball of mass. I mean, the ones I've seen are always infiltrated. They don't have a very focal area. Who knows? But yeah. All right, those are my cases.
All right, thanks. All right, who would like to go next?
I've got a couple, Jeff.
All right.
So don't try to make a diagnosis on this film here, or you will be violating the principles of Osiris here. This is not for diagnostic use, so just close your eyes. Don't have to look at this radiograph at all. But this person had a really bad headache and was admitted to the neurology service. 28 years old, has history of inflammatory bowel disease, was on infliximab for that, and has this consolidation here in his left upper lung, and do short of breath. And hope I can advance. And I have a few images here from CT. You can see that there is indeed consolidation here in the left upper lobe, and there's quite a bit of edema here in the lung. Just like that, there's edema on the other side too, with nice septal lines. And then basal stuff, kind of wonder if maybe it's dependent edema or some aspiration or something. There are pleural effusions. So let me show you some mediastinal windows. You can see this is a vigorous outdoorsy sort of person here with big muscles. There's quite a bit of lymphadenopathy and kind of smudgy looking mediastinal fat. So it looks as if there's a lot of inflammation going on here. So chest pain, fever, shortness of breath, severe headache, and stuff like that, pleural effusions in a previously healthy guy who was not having any problems on his infliximab therapy. So this is tularemia. And so it's a fairly compact pneumonia, and there's quite a bit of lymphadenopathy. And in this case, not only that, but also pleural effusion and some lung edema. So tularemia, and there was a history of some contact with animals. So I'll clarify that history by the time I post this case. So that's a case of tularemia. I showed a couple of cases of tularemia a couple of weeks ago. And here's a 51-year-old man who is a totem pole carver. He's an Alaska native, and he came in with fever, shortness of breath, and has a fairly compact pneumonia in his right base here. And it's hiding in here. We have a previous chest lateral radiograph that shows clearer vessels converging toward the hilum here. And in this case, they're smudgy. So the previous radiograph makes it easier to detect this pneumonia being in this location. And here it is on a couple of CT images, a fairly compact pneumonia, a little ground glass lateral to it. There was no lymphadenopathy here, and there is, I think there's a little bit of pleural effusion here. And this man had been exposed in his totem pole carving to a feral cat. And this is tularemia again. So I mobilized these two further cases of tularemia because it's fairly rare. It occurs in all the states, but it actually is a rare cause of pneumonias in people. There is the cutaneous form, the cutaneous glandular or ulcerative glandular form, where people get the organism introduced from the bite of a fly or a tick into their skin, or from handling an infected animal carcass or something like that. And that will cause a skin lesion, an ulcer, and then draining nodes like in the axilla may become inflamed and start to drain as well. So that's the ulcerative glandular form. The pneumonic form that I now have shown you guys 4 cases of is, I think, the rarest form of tularemia. Okay, so 4 cases of tularemia in the last few weeks.
They're multiplying like rabbits, David.
Yes. So Jeff's comment is because rabbits are the most common vector for human transmission to humans. So rabbits are often infected with this, although other animals can be. And it's contact with rabbits or rabbit droppings or rabbit,
What about
rabbit.
animals that eat rabbits, like foxes and hawks and coyotes?
Yeah, it's, lots of animals can carry it.
Okay.
Okay. So this is a new entity for me. This person has this chest radiograph from, I think, December, and has some lesions here in the apex. So we have these convexities at both apices. So this sort of thing made me think of, could this be neurofibromatosis with some neural tumors up there in the apices, given that symmetry is on both sides and everything. Other lesions I've seen up here have been things like traumatic meningoceles from motorcycle trauma and tear of a root sleeve and formation of a pseudo meningocele there. Well, there's another CT on this person. This is what I saw earlier this week. You could still see these lesions. At this point, the person has a catheter in place here for a stem cell transplant. So these lesions are still there. The catheter obscures this one a little bit, but actually I think the convexity is a little more apparent here. And if we look at this on CT, we can see that there are these bizarre apical things here, a fairly low attenuation. And then we look in the axillae here, and we see these lowest attenuation smudgy sausages here that don't belong. So these don't really look like neurofibromas, though, do they? I mean, they're low attenuation, but you got all these things in the axilla. And then as we cruise down the chest, every time we come to an intercostal, vessel, we get these little bumps here. It's as if we're skating along a corrugated surface here. Every time you come to an intercostal, you see these lumps. So all of these are swollen nerves. So this person has a condition called chronic inflammatory demyelinating polyneuropathy. And I'd never encountered this entity before. And the person's going to have an autologous stem cell transplant for treatment of this condition. So has anybody heard of this? It's considered to be like a chronic form of Guillain-Barré, which is an acute inflammatory demyelinating polyneuropathy. So
the left phrenic nerve was involved too as you were scrolling through the mediastinum.
yeah,
I've never heard of this entity. You can see, right? Keep coming up just a little.
up.
Yep. Because I mean, it looked like neurofibromatosis right in there.
Yeah, yeah. As a matter of fact, when I was showing this case to Sudhakar this morning, and he pulled out a case of neurofibromatosis that had very dramatic phrenic nerve involvement. And he described these little ears hanging off the side as the Shrek, looked like a Shrek face to him, mediastinum being round and then having these little ears protruding off it. I'll show that case next week. It's a dramatic case of really plexiform neurofibromatosis. Yeah, and in that case, you could actually follow the phrenic nerve out onto the surface of the diaphragm. So this is an inflammatory condition. They've treated with things like rituximab, and in our case, this person's going to have a stem cell transplant. When it was first detected on a cervical spine CT, our neuroradiologist thought that it was neurofibromatosis, but evidently the low attenuation, the fatty degeneration of the nerve is part of this condition. So I think the low attenuation is probably a clue to this. This is different from what I think you see with neurofibromatosis. I don't think that has the same low attenuation.
They certainly can be low just from the myelin. Maybe that's lower than typical. Or if you see large plexiform neurofibromas, they can be low attenuation. But I mean, that's an impressive case.
I'll pull out the case that Sudhakar, I'll show it next week, and I'll look at the attenuation, see if it's similar to this or whether this is distinctly lower. That would be an interesting comparison. Okay, so, you know, the chest radiograph did not lie. There was indeed something at the apex. It just wasn't what I thought it was going to turn out to be, which was neurofibromatosis, but something new.
Very cool.
And here's a little article just pulled off the internet this morning. So chronic inflammatory demyelinating polyneuropathy here, CIDP, and sometimes it's called a polyradiculoneuropathy. So it's a rare neurological thing. It's thought to be a long-term version of Guillain-Barré, except that it doesn't get better without treatment, whereas most cases of Guillain-Barré do get better somewhat, at least. And this person also had an earlier diagnosis of Charcot-Marie Tooth disease, I think, in this case. So it took them a while, I think, to arrive at this diagnosis. They were thinking of other things to explain her neuropathy before. Okay, guys.
All right.
Thank you.
It's interesting. All right.
Some rabbits, Jeff.
All right. Let's see. Peter, do you have any cases?
Yeah, I got a few.
All right. I'll give you control. There you go.
This was a good example of a case I read earlier this week. So you just see these serpiginous structures here at the lung bases. So this is, yeah, from a few days ago. And then you look back on prior studies, similar findings, not significantly changed. That was last year, and then 2020. So they're still there. So this patient has a liver transplant. So I thought this was a really good example of hepatopulmonary syndrome. There's a dilated vessels. It's probably one of the better ones I've seen. Dilated vessels at the lung bases.
Yeah, that's quite a nice example.
Yeah.
I don't think I've ever seen dilation to that degree. I mean, that's really extraordinary. Most of the time, what you see is ordinary looking vessels that go all the way out to touch the pleural surface.
Yeah.
They don't get that far, but this is the first time I've actually seen, actual dilation beyond what you saw centrally.
Yeah. This was the most impressive one I've seen. Yeah, same. And I went back like 5 or 6 years ago, and they weren't there. But
Way cool.
yeah. This is a case I had earlier today. So it came in, and let me zoom out on. So we have 2 scans. One was done at the outside hospital before it was referred to us, and I guess I don't know if at the outside it was interpreted as in our chart it was a type was called a type B intramural hematoma, and the second year resident when she was showing it to me, she said, I think this is a type A intramural hematoma, and we looked at it. So this scan on these are just 2 days apart. The scan on the right was done at the outside hospital. And then this one was done at our institution today. But yeah, so you can see this crescent shape here in the descending aorta. Kind of hard to see on the post-con on the ascending aorta. We'll get back to that. But here's the non-con. Yeah, so not the easiest to call here. There's probably some high density. There's definitely high density in the ascending aorta. And then here's our scan today. It's much more obvious. There's a crescent ascending aorta, crescent in the descending aorta. So type A intramural hematoma. Going back to the scan from the outside hospital on the right side. Let's sync these. One thing you should look for, I think, is you need to scrutinize the ascending aorta for little entry tears. So if you zoom in right there, you can see this abnormality right there, and it looks like it's a non-gated study, but this is the entry tear to the ascending intramural hematoma. So that's more evidence that this is a type A. Not that but if somebody questions it, you can always point out another finding here. And on our study from today, it's more difficult to see, but you can kind of make out the same finding right there. But this could easily be called just motion artifact. I thought it was just a good example of a type A intramural hematoma. Just you need to be careful about it with an entry tear. This was just an interesting case. 20-year-old female. Do you guys have any thoughts or ideas?
It looks like it's prevascular mediastinum, and she's a good age for germ cell, but they're usually is there any fat or anything? They're usually pretty well differentiated in female.
Yeah.
More aggressive. I would say thymic carcinoma, a sarcoma, or a very aggressive lymphoma.
It'd be a very nasty lymphoma.
Yeah, that's exactly. You guys are right. This ended up being a B cell, diffuse large B cell lymphoma.
Yeah. So she's young for diffuse large B cell lymphoma because that's a non-Hodgkin's.
Yeah, she's only 20. So I thought about I thought it would be Hodgkin's that builds the lymphoma,
Oh.
but I
Yeah, so mediastinal B-cell lymphoma happens in 30 to 40-year-olds. It looks like a non-Hodgkin's, but it's usually in that 30 to 40. So she's a little young for it, but
yeah.
they have a good response. But that's a big one.
And really severe compression here with the RVLT. I mean, I thought this was kind of pretty severe there. It's impressive for lymphomas. Usually the teaching is that it grows around vessels instead of compressing.
It's so big. There's nowhere else it can grow. I mean,
yeah, there's major compression there.
And that's also more for non-Hodgkin. Anyways, yeah, the primary mediastinal B cells can do some invasion and compression, but
yeah. Hopefully she'll respond well. She's only 20. And the last one is from my colleague Stefan Pigus. I've been showing some of his radiopedia cases, so he has another one here I'm going to show. This is a trauma case, a gunshot, young guy, gunshot wound. So this is the radiograph. These paperclip looking like markers are the entry and exit points of the bullet. It was a chest tube. And here's the CT scan. And then this is kind of the track of the bullet as it went through the lung. A lot of hemorrhage. So you can see pseudoaneurysm here. And interval radiograph, worsening airspace disease here, not right lung. And they did a pulmonary angiogram. You can see the pseudoaneurysm, which was causing mediastinal hemorrhage or pulmonary hemorrhage, and it was coiled. The patient got much better. It's just a nice example of a gunshot injury to the chest.
Yeah, that's a good one.
Yeah, that's all I have today, guys.
All right, thank you. All right, guys, unless there's anything else, we'll finish a little early today. Thanks for the good cases.
Take care, guys.
Yeah,
guys, take care. Bye.
bye.